further ado.
Thank you. Thank you. All right. All right. Good morning. So this is on thyroid hormone replacement, and there's new data on suppressive doses of thyroid hormone. Like Tommy said, please ask any questions. I'm pretty good about repeating the questions, so you don't necessarily have to jump up to the microphone if you're 4 deep in the aisle. Ask questions at any time, but there's certainly going to be plenty of time for questions at the end. I think I don't have too many slides. So I don't have any disclosures for this talk. And, you know, it's important, I think, first of all, to just kind of understand this whole axis. What are we measuring when we're checking your thyroid hormone levels, and what do they mean? So this is a little mock-up of the oh boy, what happened? So hypothalamus, which we actually don't measure hormones from the hypothalamus clinically, but the pituitary gland talking to the thyroid and then sending thyroid hormone out to the periphery. And this is a way to see things easier. So the way that the axis works is from the hypothalamus, high up in the brain, there's a hormone called thyrotropin-releasing hormone, TRH. Again, we don't really measure that in clinical practice. That stimulates the pituitary gland to secrete TSH, thyroid-stimulating hormone. It stimulates the thyroid gland to make thyroid hormone. And then it may be hard to see from the back, but the thyroid secretes directly T4 as well as a little bit of T3. The arrows are of different size here. That's for a reason, because the majority is T4. And then T3 is the active hormone, and the vast majority of T3 comes from peripheral conversion. So, enzymes in the liver and the muscles and other tissues will generate T3, and then importantly, critically, what happens is this feeds back and it suppresses TSH. It also suppresses TRH, but again, we measure TSH. Okay, so it's always in this balance. And the terms I use to describe this when I'm talking to patients is it's kind of like when you set the heat on your thermostat, okay? So if you set the heat to 72 degrees and your house is 68 degrees, it's going to kick on, right? It's going to kick on and heat up the house. So that's kind of like the thermostat sensing the temperature is low, and it kicks on the signal to the furnace to make the heat. If you set the thermostat to 72 degrees and the house is 74 degrees, it'll never go on. It's getting that feedback that it's already warm enough, there's no reason to go on, and so that's this kind of feedback, okay? And so you don't run around your house, at least I don't, and say, it kind of feels like it's about 68 degrees, I just checked the thermostat, all right? And that's really what we're doing when we check TSH. It's kind of your set point for thyroid hormone. So it is, in my opinion, the single best test to screen for thyroid dysfunction, for thyroid status. It indicates your individual set point. There's pretty wide variability of T4 and T3 levels within these ranges, but the TSH moves logarithmically based on those levels, and I'll show you an example of that on a slide. So it's elevated in primary hypothyroidism. Everyone with a history of thyroid cancer who has surgery has primary hypothyroidism. They have no thyroid, okay? So if you don't take thyroid hormone, you're going to lose that feedback and TSH is going to go up, okay? It's suppressed in primary hyperthyroidism, okay? If the thyroid's generating too much thyroid hormone, or if your doctor after a thyroidectomy is giving you excess thyroid hormone, your TSH will be low, okay, because you get that feedback. When can you not rely on the TSH? If the pituitary gland is abnormal. If there's been pituitary damage for whatever reason, surgery, tumor, car wreck, something else, the TSH is always going to be low, right? If the pituitary can't make TSH. So that's really the only time when we don't rely on it. And for walkie-talkie people who don't have significant medical problems, the pituitary is almost always normal. So do put a lot of stock in that level. Okay, so let me show you this slide. Yes?
Yeah, sorry.
Yes.
After being on suppressive dose of Synthroid for 45 years, can that affect the pituitary's ability to put out TSH?
So the question is, after 45 years, all right, yeah. Congratulations. Of suppressive doses of thyroid hormone, can that affect the pituitary's ability to put out TSH? You know, it might. I mean, excess thyroid hormone will literally cause atrophy of those cells. But I do believe that if you take away that thyroid hormone, they should recover. And we certainly have patients who clearly recover. So I don't think it would be permanent, but I don't think I've ever done that experiment. But I think if you adjust the dose down, for example, even with 40-plus years of thyroid hormone, the TSH will rise. Yeah. Yeah. Okay, so this is a great graph, I think, that illustrates kind of what we're talking about in terms of how the TSH is so helpful. So this middle line here, this middle stripe is normal range, okay? So here's euthyroid. All the levels are in the normal range. Okay? This is subclinical hyperthyroidism. It's a terrible name. It has nothing to do with symptoms. Okay? It is this lab pattern where the T3 and T4 are rising within the reference range, but the TSH is suppressed. Okay? And then you get to overt hyperthyroidism where the T3 and T4 are frankly high and the TSH is low. But this is what we're talking about when we talk about suppressive therapy with thyroid hormone. And you can see here that even within the reference range, as these rise, TSH will drop. The pituitary is sensing that there's too much thyroid hormone and it shuts down. Okay? And that's why I believe, and most thyroidologists believe, that this is such a good indicator, because even subtle changes within this quote-unquote reference range will cause big changes in TSH. Okay? So this is, in general, what we're shooting for when we're talking about suppressive doses of thyroid hormone. We don't want people to be overtly hyperthyroid, but we do want TSH to be low, and of course, that's what we're going to get to. Why do we want TSH to be low? Okay. This is why we want TSH to be low, okay? Because differentiated thyroid cancers, papillary thyroid cancers, follicular thyroid cancers, they have functional TSH receptors. They respond to TSH. And so TSH does not just make thyroid cells make thyroid hormone, it can make thyroid cells grow. We don't want that, right? If we think that there's thyroid cancer, we don't want a signal causing growth. So TSH is kind of like fertilizer for thyroid cells. When you see those pictures of folks from like sub-Saharan Africa or the hills of Vietnam with those huge goiters, the mechanism of that is that they're from iodine-deficient regions. The thyroid needs iodine to make thyroid hormone. The pituitary senses a lack of thyroid hormone and rises, okay, trying to make excess thyroid hormone, and that will cause growth, hypertrophy of the gland. Okay, that's the mechanism. So again, we don't want growth and hypertrophy of thyroid cancer cells, so we want TSH to be relatively low. Okay? So how do we do that? Well, there's several different forms of thyroid hormone replacement therapy, and I want to go through those different forms because it's relevant to anyone who's had a thyroidectomy. They need to be on some form of thyroid hormone for the rest of their life. So there's armor thyroid, sometimes called nature thyroid. That's desiccated thyroid hormone, usually from pig thyroid. It used to be cows too, but mostly pig. There's levothyroxine. LT4 is levothyroxine plus liothyronine or T3 cytomel combinations. And then levothyroxine, which would be sort of considered the gold standard. Okay? So armor thyroid. So in Colorado, we have the Greater Republic of Boulder, where people often come and say, I want natural therapy only. Give me the natural stuff, doctor, okay? And that's fine, but my take is that armor thyroid is not natural for humans. Why do I say it's not natural for humans? Because it comes from a pig, right? It doesn't mean it's inherently bad, but when I hear that, I want something natural. It's just, I don't know why anything from a pig would be natural for a human. Oftentimes people will say to me, well, it's not synthesized in a lab. You know, it's made from nature, but it's not as if you're taking it directly from the pig's neck into your mouth. This all goes into a lab and it's compounded and it's put with binders and made into a pill. So, you know, it's not natural for humans, and it's actually physiologically quite different from what a human's thyroid produces. So let's talk about that. So here's the thyroid, and it's producing thyroid hormone, and the dark bars here is what's directly produced from the thyroid. So the vast majority of what is directly produced is T4, okay? There is a little bit of T3 produced, okay? But the vast majority of T3 is converted in the periphery, all right? So T4 is the primary secretory product. It's the primary hormone that the thyroid makes. And then T3, there's a little bit that's directly produced from the thyroid, but the vast majority, about 80%, is derived from this conversion in the periphery, okay? And the ratio ends up being about 10 to 12 to 1, T4 to T3, all right? That's natural for humans. That's what a human thyroid produces. This is a study looking at what are the relative ratios in desiccated thyroid hormone. So 4 different lots of desiccated thyroid hormone, and the T4 to T3 ratio is about 4 to 1. So there's about 3 times as much T3 in animal thyroid, at least pig thyroid, than what a human produces. Okay? So again, that's a very different molar ratio. It's not the same physiologically. So we worry about variable content of T4 and T3 in these lots because, I mean, animals get thyroid disease too, all right? I'm not saying that there's a bunch of hyperthyroid pigs and a bunch of hypothyroid pigs and they all get mixed together, but there is variability in thyroid content in humans and I assume animals. There does tend to be more difficulty in titrating the correct dose of this medication. T3 has a much more rapid absorption and a much shorter half-life than T4, so there can be a little bit of this variability. And we worry about potential cardiac risks, especially if we get supernormal levels of T3, okay? Now, that doesn't mean that Armour Thyroid is devastatingly bad. This drug has been around longer than I've been alive, and you don't read in the papers about, huge mortality risks with Armour Thyroid. This is a study that I think is important to go over, but it is important to recognize this is not in thyroid cancer patients, okay? There's never been a study with Armour Thyroid in thyroid cancer patients that I'm aware of. But this is a study that came out in 2013 that looks at the ability to regulate patients on Armour Thyroid. So it was 70 patients, age 18 to 65, who were on a stable dose of levothyroxine, okay? They had been on it for at least 6 months. So it was a double-blind, placebo-controlled crossover study, meaning that the pills were not labeled. The patients didn't know if they were getting Armour or levothyroxine. They took one for a certain period of time, 16 weeks, and then they crossed over and took the other for 16 weeks, again, not knowing which was which. So everyone was blinded, and they served as kind of their own controls, okay? And the primary outcomes were what were the biochemical tests, what were the thyroid hormone levels, and quality of life. Because certainly, patients say, I absolutely need Armour Thyroid, or I feel better on this, or I don't feel good on levothyroxine, and quality of life is very important, okay? So, too small for you to read, but let me just give you the highlights. DTE is desiccated thyroid extract. That's the Armour Thyroid versus levothyroxine. The T3 levels are statistically higher in the Armour Thyroid. No surprise there. The T4 levels are higher in the levothyroxine. No surprise there. But what these investigators did very well is, at least for this short period of time, is the TSH, statistically different, but right smack in the reference range. Again, this is hypothyroidism replacement, not thyroid cancer dosing. 1.67 for the desiccated thyroid hormone extract, 1.3. What I would say is, quote unquote, perfect replacement based on the biochemical levels, okay? So, what were the outcomes? The patients showed no difference in symptom scores, general health questionnaires, or neuropsych testing, okay? So, I would interpret that as a negative study. Not that patients did worse, but when they didn't know what they were on, they couldn't tell any difference. Their quality of life was not any better or worse. When they then asked patients, well, did you prefer being on lot A or lot B, because they were on one or the other, 48% preferred desiccated thyroid extract. And so the holistic community uses this and says, see, it was better. Even though they didn't know, 48% preferred it, even though the quality of life was not different when it was tested. There were no adverse outcomes in any group, okay? So it's important to recognize that this group, the group that preferred this, had an average of 4 pounds weight loss over the course of that arm. Now, the study was not meant to be a weight loss study. The outcome was not weight loss. So was that due to the desiccated thyroid extract? I mean, we don't know, maybe. It's not an unreasonable conclusion, but this was something that was noted. Okay, so how do I interpret it? So this group had more weight loss, and maybe they liked it because of the weight loss, and whether that was due to that extract, I don't know, okay? But remember, 48% preferred it, but 52% didn't, okay? I mean, it's not as if 48% is 98%. They either preferred levothyroxine or had no preference. So again, I consider this to be kind of a negative study, not that it was bad, but that there really was not any significant improvement. It was a short trial, and I think what needs to be done next is we need to look at a comparison of T4, T3 combination that I'll talk about as opposed to just levothyroxine alone, okay? So again, not thyroid cancer patients, but replacement for hypothyroidism. It was well done. It's a randomized controlled trial. That's kind of our level A evidence when we talk about that. And there certainly was no harm, but again, I would argue not a lot of benefit. This is from David Cooper. He's one of the quote-unquote godfathers of thyroidology out of Johns Hopkins, and he feels like there's really no place for this drug in thyroid cancer management because we have such a narrow therapeutic window that we're shooting for. When we're talking about these TSH levels that are at this narrow reference range, it's definitely, in my opinion, in my experience, more difficult to get at that stable range because of the T4, T3 content. There's a lot more variability with that T3 going up and down. Difficulty with titration, and again, at least a theoretical risk of cardiac risks when you get high levels of T3 that may be stressful for the heart, increasing its metabolic rate. Okay, So what about T4, T3 combination? If the thyroid typically makes T4 and T3, it really makes perfect sense that that's what we should replace with, right? I mean, it makes sense to me. So let's look at this study that looked at T3 levels in patients who had thyroid surgery. Now again, importantly, this was not patients with thyroid cancer. They actually excluded those patients because they wanted to have just normal physiologic replacement. This was a prospective study. This was out of Georgetown. They took 50 euthyroid patients, perfectly normal thyroid function, who were going to surgery for concern about cancer, or they had an atypical nodule or compressive symptoms or something. And they looked at the thyroid hormone levels before and after levothyroxine alone, okay? And they were aiming for a normal TSH. So 33 were included who did not have thyroid cancer because, again, the TSH goal is different in those patients. So this is reflective of the pre-thyroidectomy TSH levels. So they checked it twice at about 6-week intervals. And here people are right around 1, very stable, nice, normal TSH levels. And then this is 6 weeks after surgery and 6 weeks after that. And so there's a big splay here because we give kind of a weight-based, educated guess dose after the surgery, and then that's modified to get an improved dose down at the normal TSH range. But statistically, these are actually all the same, okay? I mean, there's a much wider variation here, but the average was all the same. So got the TSH level to, where the goal was. Here's the T4 levels, and so this is pre-thyroidectomy, post-thyroidectomy. Again, not surprisingly, the absolute levels are higher, but statistically, these are actually all within a statistical similar range. And then here's the T3 levels, pre-operatively and post-operatively. They're all the same, okay? These patients were not getting T3. So to me, this demonstrates how very, very efficient the periphery is with these deiodinase enzymes of converting T4 to T3. And you can have normal T3 levels. And whether that's compensatory or I can't explain exactly why this occurs when that direct T3 is not coming from the thyroid. But it just shows that the body is very, very good at regulating and maintaining T3 levels, even with just levothyroxine alone, okay? This is not meant to be read, okay? This is just a slide that shows a variety of studies looking at T4 and T3 combination, okay? So again, most of the time patients were blinded as to whether they were on T4 plus placebo or T4 plus T3. And I'm just going to highlight this section that looks at several studies as to whether patients felt any kind of benefit or whether there was any physiologic adverse outcome. And 1 out of 9 studies showed a benefit of combination therapy, meaning that patients felt like there was some benefit. So 8 out of 9 didn't demonstrate any benefit that the patients could tell. And 4 out of 6 studies where they looked for adverse events did show some kind of undesirable effect. Heart arrhythmias, suppressed TSH levels, something that the investigators would say, this is something that we have to adjust. Okay, again, this is not thyroid cancer, this is just thyroid hormone replacement, but sort of showing that T4, T3 combination, although it makes a lot of sense based on what the thyroid produces, when studied, really doesn't show a significant benefit. So should all hypothyroid patients be treated with this? Probably not. It's extra cost. There's no difference in the T3 levels, and patients can't really tell the difference when they're blinded. Should any hypothyroid patients be treated? Yeah, I think so. I mean, I don't have to tell this group, okay, at this meeting that it is not the same when your thyroid's removed, that people, even if the numbers look perfect, don't necessarily feel good. And so I think it's important that we work with patients to sort of say, let's try something that's safe, as long as we do no harm, to see if you can feel better. I mean, there is no harm, in my opinion, to trying to add in some T3 at physiologic ratios of what a human thyroid produces to see if there's improvement. Because, I mean, absolutely, anyone who does a lot of this work knows that some people, they get 8 hours of sleep a night, they exercise, they don't have life stressors, their TSH is perfect, and they just don't feel the same. You're not the same. You're not the same, okay? You used to have your thyroid worked well, now your thyroid's gone, okay? So it's reasonable to try. But again, when patients are blinded, when the placebos are incorporated and people don't really know, they really can't tell, okay? And so it doesn't mean we shouldn't try, but it's important to recognize that even if you don't feel better, it's okay to just stop because it's medically safe to be on levothyroxine. When we use combinations, I always recommend that we try to aim for a physiologic dosing. 10 to 1, the math's easier. Okay, I can't do 12 to 1, all right? 10 to 1. So that's what I'll try with patients who just don't feel quite right on levothyroxine alone. This was a study that did look at T4 and T3 combination therapy in patients with thyroid cancer. And I'm not going to run through the data, but this was in 2007, and there was no evidence that combined therapy resulted in improved well-being or cognitive function or increased activity on peripheral tissues. So again, doesn't mean that a subset of patients don't feel better on that therapy, but in this study where patients were blinded, they couldn't really tell the difference. Okay. And so what about levothyroxine? So when we talk about suppressive doses, we do kind of a weight-based dose. The typical replacement, aiming for normal thyroid hormone levels, is usually about 1.6 micrograms per kilogram. And so for suppressive doses, we increase the dose. That increases the feedback to suppress TSH. And, it's about 2, okay? And that's where we'll typically start. And, I've seen women smaller than me who need 200 micrograms, and I've seen huge guys only need 100 micrograms. And so there's some patient-specific variability, and you just have to titrate the dose to the goal. Okay, there's no right dose. It's just whatever the goal is. It takes 5 half-lives to reach steady state. The half-life is about a week, so recheck in 5 to 6 weeks. Okay, if you get started on a new dose because you're not feeling well, it's not appropriate to say, I don't feel better a week later, because it takes a while to build up in your system. Okay, so definitely have to be patient to have that evaluated. And you want to recheck when it's at steady state so that you're not stacking on doses up or down and then getting into trouble. Yeah?
Just a quick question. I know some doctors have prescribed it where you take the same dose every day. Some have just prescribed it where, just because of the half-life, say 8 pills in a week. Because of the half-life, is there a big concern there about kind of different doses for different days?
Yeah, so the question is about different dosing strategies, because there's quite a few doses, but there may not be the perfect dose for you. So, for example, the next single pill dose from 175 is 200 micrograms, okay? Well, that might be too much, and 175 isn't enough. So how do you get to 188? Well, you could do 188, but that doubles your cost. Sometimes what we'll do is we'll say take 175 6 days a week and take 1.5 pills on the 7th day, and because of the half-life, as you've mentioned, it's so long that you'll even out to about whatever that is, 188, and that's perfectly fine. I really think that's fine. For patients that are, say, how shall we put it, challenged to be consistent with their therapy, some clinics will give a week's worth all at once in a day. You come into my clinic, you're going to take 7 pills right now, and then you're going to come back next week and it's directly observed therapy, and they actually get reasonable control of their levels. You'll definitely get a pop there, but I do not recommend that, okay? Do not do that, okay, to make it easier, all right? This isn't being recorded, is it? Okay. You're much better off if you take consistently the dose, on an empty stomach at roughly the same time. If you get up at 6 on the weekdays and sleep till 8 on the weekends, that's totally fine. But you'll do the best if you take it consistently. But with this long half-life, yeah, you can take 6 pills a week and skip the 7th day to get the right dose. You can take half pills. We do all that kind of stuff to try to get that narrow therapeutic window. So that's fine. Yeah. Okay, so I'm coming to, so the question is that I haven't mentioned Synthroid yet, and is it as good as levothyroxine? So I'm coming to that right now. Okay? Yeah. So that's how we recheck. Okay, so I'm going to show some hardcore science in this patient-centered meeting, okay? I probably shouldn't do it, but that's okay, because I want to show you that there is some biologic evidence that actual levothyroxine may be better for suppressing TSH at the level of the pituitary than T3. So this is a study that is looking at type 2 deiodinase. So deiodinases clip off an iodine from T4. You take away an iodine, and now it's T3, okay, deiodinase. You take one of those off. And this top line here are the T-alpha T1 cells, which are pituitary thyrotropes. These are the cells in the pituitary gland that make TSH and that generate that hormone. And these cells on the top line have the highest level of deiodinase. Okay, so that's relevant because when we treat with thyroid hormone, and we look at whether you're on too little thyroid hormone, just the right amount, or excess thyroid hormone, these T-alpha T1 cells, these pituitary thyrotropes, actually generate more T3 than non-thyrotropes, okay? And results in significant TSH suppression, all right? So this is not T3 doing that. This is a local conversion of T4 to T3 by this sort of robust expression of this enzyme that will convert the inactive form to the active form. So, at least it gives some biological basis that maybe T4 is the best drug for suppressing TSH. And it certainly is much more stable and, in general, easier to kind of regulate. So, again, some biological basis for why T4 is really good at suppressing TSH and a drug that's very easy to maintain and regulate. So, again, thyroid hormone feeds back to inhibit TRH and TSH. Type 2 deiodinase is preferentially active in the CNS. It converts T4 to that active hormone, which will suppress TSH. And again, this is the feedback. Nobody has a thyroid anymore if you've had thyroid cancer surgery, so we up or down titrate the dose of that pill to get to our proper TSH level, okay? So levothyroxine, generic versus brand name. That was the question that came up. Yeah?
Are there people who don't convert the T4 to T3?
So the question is are there people who don't convert T4 to T3? The questionable slow converters has been brought up. So there is one study that I'm aware of that looks at T4, T3 combination and patients who felt better on the T3 combination as opposed to T4 alone, okay? So the study was not designed to look at enzyme differences, but what they did is they took out the subset of patients who, again, on average, there was no difference. But, on average means some did better and some did worse, and they looked at the people who did better. Okay, so you're immediately selecting for a population that's a little bit different than the original study, and that's important to recognize. But they looked at those patients who said, yes, I definitely felt better on A plus B, not A plus placebo. And then they did enzyme analysis on those patients, and it looked like they had a genotype that had a little bit of a difference in one of those enzymes, and it suggests that maybe they don't convert T4 to T3 as readily. Again, T3 levels are normal, but maybe it's this kind of quote-unquote slow conversion, what's it, who's it, nobody really knows, okay? So I don't believe there's anyone who does not convert T4 to T3. I mean, I just don't think that's physiologically possible. No one would be able to survive on levothyroxine, okay? But there is some suggestion that maybe some people are different, and I think, that makes sense that some people, when they take T4 plus T3, they say, I don't feel any better, and it's just wasting my money, and let's just go back to levothyroxine. And some people say, oh my gosh, doctor, thank you so much. I just feel so much better, and I don't have a great explanation, but as long as it's safe and they feel better, man, that's great. Okay, so that's my answer to that. And I think there is more literature and more investigations coming out about that because it's kind of a hot topic right now. But I don't believe there's anyone who just does not convert. That's not physiologically possible. Okay, so kind of coming to the question about generic versus brand name. So levothyroxine is the active drug. All thyroid hormone replacement, whether it's a brand name or not, is levothyroxine, okay? And levothyroxine, even though it's synthesized in a lab, is molecularly exactly what the thyroid produces, that T4 component, okay? So again, when we kind of get into this argument about what's natural and what's not, even though it's synthesized in a lab, I would say that, this is more natural. It's definitely more physiological because that's exactly the hormone that's produced. But the concern about generic versus brand name is that the preparation, kind of all the stuff that makes the pill a pill, can be different, and that can lead to differences in absorption, all right? So if pharmacies get a different brand name or a different generic from a different manufacturer every 3 months, is that going to alter the amount that's relatively absorbed in your TSH level? And the answer is, yeah, it can be. The disadvantage of prescribing brand name is just cost, okay? So Synthroid is, a great drug. It's levothyroxine. There's nothing special about it in terms of the levothyroxine content, but it's always Synthroid. It's always made from the same manufacturer. It's always made with the same processing, and you're always going to get Synthroid, okay? If you get generic levothyroxine, if the pharmacy gets a better deal for the next 6-month lot from someone else, the FDA says you can do that. You can switch that, but it clearly might have a little bit of a difference, and I'll show you the slide on that. Now, I'm working in the Kaiser system now. Everyone gets levothyroxine unless they specify wanting a brand name, but Kaiser's had the exact same manufacturer for the last 15 years, and that, to me, is fine. It's not that there's anything better about Levothyroid or Levoxyl or Synthroid, it's consistency. And if you can guarantee that you get the same generic preparation, that's fine. It's all about consistency, okay? So this is what the FDA says. They say that you have a reference range for a drug, so this is our reference drug, and then you have this kind of confidence interval about how much is absorbed, and as long as the confidence interval falls within 80% to 125% of the reference range, then that's quote-unquote equivalent, okay? So product A here would be equivalent to the reference, but product B would not be because this reference range falls outside this threshold. But let's just say that this is a 12.5% difference that the FDA says is equivalent. Well, if you go from 125 micrograms to 137 micrograms, which is about 10, 12%, your TSH is going to change, okay? I mean, guaranteed. So it may not be truly similar when you have different generic preparations. Now, what I will say is that all thyroidologists warn about this. All patients have had, some patients have had experiences where their TSH changes, but in reality, it's usually not this extreme. What I advise people is that the color coding is all the same for the different dosages, but the pill shape is usually different. So if you're on generic because it's $4 a month at Walmart and you don't want to pay $30 a month for Synthroid, if you go to Walmart and the shape of the pill has gone from an oblong shape to a round shape, it's still levothyroxine, it's still the active drug, but you may want to get your TSH checked about 6 weeks later, just to make sure that you're absorbing it the same. And that's all, okay? So consistency is important, especially when we're targeting a narrow therapeutic window, but the active drug is the same in all. Yeah?
Are pharmacies required to disclose that to patients?
So the question is are pharmacies required to disclose that to patients? No, not that I'm aware of. Again, that's why I'm saying pay attention, and if the pill shape changes, you've probably got a different generic preparation, because the FDA says they're the same. Yeah, so. Okay, so again, branded therapy is important, whether you're just sort of sensitive to minor changes in thyroid hormone levels, but it's definitely important to have consistent therapy for thyroid cancer management because we're going to be walking this very narrow therapeutic target, okay? We talk about when you have aggressive disease, we require more stringent TSH suppression. For those who are elderly patients, we don't want them to get super physiologic levels of thyroid hormone and maybe have cardiac toxicity. We just want to minimize as many variables as possible, okay? Okay, so what's the target, all right? Now, these are the 2009 guidelines, and I'm going to kind of go through this exercise that may not be worthwhile, but we have the time to do it because we have new data this year that is really sort of paradigm shifting in terms of our TSH suppressive doses. But this is 2009. The 2015 guidelines are not out yet, but they're probably going to address this. So initial TSH suppression, so this is right after therapy. TSH suppression to a level below 0.1 is recommended for high and intermediate risk patients, okay? So the reference range for most labs for TSH is 0.3 to 3, 0.5 to 5, somewhere in that range. So this is low. And again, they're talking about hitting it below this. If you have lower risk patients, then just slight suppression, 0.1 to 0.5 is appropriate, okay? So why not just suppress everyone? You know what, if this stuff causes thyroid cells to grow, let's just knock it down all the way, get the TSH low, and not even worry about it, okay? Because it's toxic, okay? Again, do no harm. I mean, that's our first charge as physicians, and it can be toxic to the bones and to the heart. So, bone disease, there's evidence of increased bone turnover markers and worsening metabolic bone disease, and then atrial fibrillation. So atrial fibrillation is when when people talk about palpitations, usually people say palpitations and they're actually not having true atrial fibrillation, but this is where you get an abnormal cardiac rhythm where the signaling through the heart isn't appropriate and you can get clots develop and just poor blood flow. And maybe too small to read, but basically when the TSH is suppressed in patients over the age of 65 was the population in the study, there was a twofold increased risk of atrial fibrillation. So again, it may be where the thyroid cancer suppression outweighs that risk, but the risk is definitely there, okay? TSH suppression in bones, this is just looking at a bunch of meta-analyses, meaning that they smushed together a bunch of studies and tried to analyze the data. Premenopausal women, not as big of effect on bone mineral density. Only 2 of 12 studies showed a decrease. Postmenopausal women, more of an effect. Older men, not as much of an effect. This is from 2006, but we have new data from this year that came out looking at TSH suppression on the risk of osteoporosis without decreasing recurrence risk in low and intermediate risk patients. Okay, so these are patients without metastatic disease. These are patients without huge aggressive tumors. 570 women almost with low to intermediate risk thyroid cancer. The mean age was about 48 years. They were followed for an average of 6 years, and they looked to see if the average TSH was less than 0.4 or greater than 0.4. Now, I've read this study, and it's out of the aspect of this conference per se, but I would definitely quibble with the way that they described osteoporosis, the criteria that they used. It's a little squishy, the definitions they use, because, for example, one of the definitions was a doctor just put them on a bone agent. Well, that doesn't mean that they absolutely had true osteoporosis, but the point being that bone mineral densities were lower, or they felt like they had to be on therapy, and what was the difference? So this is looking at the TSH level at 0.4 or then higher, and the risk of osteoporosis. So the dark bars are the osteoporosis, and the stars here are statistically significantly higher than those patients who had the higher TSH level. And then this is the disease recurrence, and this is all the same. Okay? So there was no adverse effect in this study on disease coming back, but there was worsening bones. They used this higher threshold for statistical significance. I'm a little surprised that the editors allowed that. It's kind of naughty. It's not standard statistical assessments with a p-value of less than 0.08. But again, the point being that it did look like there were adverse effects on the bones, but no improvement or adverse effect for the thyroid cancer. So if it doesn't help, it only hurts. Okay? So this is going back to the 2009 guidelines, and again, too small for you to read, but I'll just go through the highlights. This is for long-term TSH goals. So after your initial therapy, do patients have thyroid cancer, persistent or not? Serum TSH should be maintained below 0.1 indefinitely if there is evidence of persistent disease. Okay? In patients who are clinically and biochemically free of disease, you may want to maintain a moderate suppression for 5 to 10 years. That's 0.1 to 0.5. And those patients free of disease, you should let them kind of rise up to a low normal range. Okay? So that at least has been around since 2009 and even longer. And I think that's important because patients who have no evidence of disease, there is no indication to maintain a low TSH. I mean, it really is just adding harm without any benefit. So we definitely see patients in referral centers who had their initial diagnosis in 1983 and they've had no evidence of disease and their TSH has been 0.05 for 45 years or whatever. And so, again, that's not necessarily beneficial. It's bad for the bones. It's bad for the heart. If it doesn't help, it only hurts. Yeah?
I don't know how relevant this is, but in the case of Hashimoto's, when your levels go up or down, how will you maintain a consistent level, given that it's up 5 to 6 weeks before you find out it's working?
So the question is about Hashimoto's and if there's alterations in levels. So if the thyroid has been removed, the whole Hashimoto's thing kind of goes away in terms of regulation. Now, there's some, again, very soft evidence that suggests maybe there are some symptomatology associated just with the autoimmunity of Hashimoto's itself. But in terms of regulation, it should be a non-issue, in my opinion. Patients who have their thyroid intact and are undergoing this transition with Hashimoto's, I mean, it can be a little bit of a roller coaster, but the autoimmunity of Hashimoto's should not affect thyroid hormone replacement at all. That I'm aware of. I've never seen any studies about that. And again, I mean, the thyroid's gone, so those antibodies just don't have anything to react to anymore. They don't react to the thyroid hormone itself. It's actually enzymes within the thyroid cells that they react to. Yeah?
Could you just give a brief summary, even without the details of this paradigm shift you mentioned?
So the question is, can I give a some? Yeah. Okay, so the question is, can I describe this paradigm shift? I'm going to describe the paradigm shift. Do you think I'm going to talk about that and then not get there? It's coming up, okay? So this is yes. The answer is yes, I will, and I'm going to give you some details, but just the right amount, I hope. So it's coming right now, I think. Okay, so what are the data gaps? I mean, I just described, kind of what these 2009 guidelines say. Well, what about aggressive presentations of stage 1? Remember, if you haven't been to a session yet at this meeting, go to a session on staging. Staging is all screwed up, okay? If you are 42 years old and your entire neck is replaced with thyroid cancer, by definition, you are stage 1, okay? If you're 46 years old and you have one lymph node involved, by definition, you are stage 3. I'm much more worried about the 42-year-old than the 46-year-old in this case, okay? But really, there's no data that suggests that these aggressive stage 1 patients should have TSH suppression. But I mean, I think they should, right? Kind of makes sense that they should. What about aggressive presentations of stage 2? So age 46 with a greater than 2 centimeter tumor is stage 2. Age 44 with distant metastases is actually also stage 2. I'm more worried about this patient than this patient. Should they have the same level of TSH suppression? Maybe not. And what's the goal of TSH after no evidence of disease? Again, do you have to wait 5 to 10 years? What if you have no evidence of disease in 1 year, in 2 years? I mean, is it really worth putting someone on TSH suppression for that long, just for the heck of it, just to be safe? I mean, I don't know. So again, let's look at this recommendation. TSH below 0.1 for high-risk disease, mild suppression for 0.1 to 0.5. So to me, what this says is stage 2, don't have a normal TSH or higher, but I don't really know where to go, how low. Stage 3 or 4, don't have a TSH greater than 0.5, but should it be 0.01? Should it be 0.1? I mean, there's a lot of variability in there. Should we suppress it all in stage 1? Ever, okay? I mean, again, these are questions that are not driven, that don't have answers driven by data. But I think, again, if it's aggressive, you should suppress. Okay, and finally, this last example before I get to the paradigm shift. 63-year-old male with stage 3 disease because he had 2 out of 10 lymph nodes that were involved, got radioactive iodine, and now his thyroid globulin is 0.6 and stimulated it's 1.8, but we can't find any disease. His TSH is 0.26. Is that right? I mean, if you have quote-unquote aggressive disease by stage 3 criteria, and you have detectable disease, those guidelines would say you should be less than 0.1. But this guy feels great. So do I change it? I mean, it sounds like it's kind of nitpicky, but I mean, we run into this all the time. Patients run into this all the time. So there are significant kind of gaps in the knowledge, but I think that this analysis that came out this year really is going to help us smooth out a lot of these questions, okay? So this is the National Thyroid Cancer Treatment Cooperative Study Group. It consists of data from 11 academic centers. University of Colorado is one of them. It's housed at the MD Anderson Cancer Center. It's been going on since 1987. I believe the last iteration was 2006, where they looked up to 2006 for the data, and now they've got up to 2012. About 5,000 patients, average follow-up of about 6 years, which isn't too terribly long, but I think the last iteration was 3.5 years or something like that. And they looked at TSH suppression and survival by stage of disease, okay? So they used stage 1 through 4 disease without distant metastases, and then anyone with distant metastases. So even if you were young, they said you have aggressive disease, and that's distant metastases. Okay, so if you can't read it from the back, this is survival. This is stage 1 disease, and the 2 superimposable lines here are an undetectable TSH versus a subnormal to normal TSH. So basically anything below 0.5 was kind of the criteria they used, 0.3 to 0.5 depending on the center. And then if you had a higher TSH, normal or high, you had a worse outcome, okay? So this is going to be the theme. Stage 2 disease, overall the survival is a little bit worse, but still very favorable, over 95%. But again, undetectable versus subnormal, superimposable lines, worse if your TSH was high. Stage 3, same thing. Again, we're getting worse survival overall, but again, 10-year survival is still 80+% by cancer standards, good outcomes. But these lines are pretty much superimposable. Bad if you have a high TSH. Stage 4, and distant metastases, okay? So I think what this data is showing us is that a normal to high TSH is bad, but anything below that lower limit of normal is probably the same. And this very strict TSH suppression that we've all been trained to do is probably not worth it. It's probably not helpful. And if it's not helpful, it's only harmful, okay, in terms of our TSH goals. Yeah? Yes, so the question is about medullary thyroid cancer. So medullary thyroid cancer is not thyroid cancer. Medullary thyroid cancer is a neuroendocrine tumor that happens to live in the thyroid, and they do not respond to radioiodine or TSH suppression, so the goal is just normal, euthyroid. And for me, when I'm replacing people, whether they have Hashimoto's or whatever reason, it's just low normal. 85% of the population lives in the lower half of the reference range. If you have a TSH before your thyroid's taken out, you kind of want your TSH to be there. But if I don't have that data, one, is basically my goal. So yeah, TSH suppression is contraindicated in medullary thyroid cancer because it doesn't help. So, I mean, this really is very, very different from the way we've all been trained, where, if you have aggressive disease, you need to have a TSH below 0.1. This would suggest that you have similar outcomes if you're anywhere kind of at that lower reference range to slightly below it. And I mean, that's a good thing. I mean, it's a good thing to know that if someone feels good with a TSH of 0.2 and you're maybe mitigating that risk of atrial fibrillation, for example, as opposed to pushing them down, you're probably not making their thyroid cancer worse. Okay? Is that enough detail or not too much? Is that okay? All right. We did it. Okay. So aggressive thyroid hormone suppression confers no additional benefit over modest suppression. That's the take home, okay? Again, there's definitely, this is not quote unquote level A evidence. This is retrospective reviews. There's a whole variety of reasons why TSH goals may have been different in patients, and I'll get to some of that here in terms of recommendations. But at least when you look back over, that period from 87 to 2012, now that there's more patient data, more patient years of follow-up, it does not seem that this very strict suppression is helpful. So these are the guideline kind of recommendations for TSH suppression goals from the European Thyroid Association and the American Thyroid Association. And so over here, these are all high-risk patients, and they talk about being up to 0.1 but below, and so maybe now it's going to be at 0.1 when you have initial low to moderate risk patients, kind of between 0.1 and 0.5, and maybe that's all these arrows are going to shift over. And then if there's no evidence of disease, allowing the TSH to just be somewhere in the low normal range is appropriate, and I'd certainly agree with that. And this is a nice review that was put out by Dr. Cooper and Biondi from Johns Hopkins. Dr. Cooper's from Johns Hopkins, and he just talks about how we don't treat people in a vacuum. They may have risk factors for excess thyroid hormone that you have to consider, and so if they have a high risk from thyroid hormone therapy, let's say they have an underlying cardiac arrhythmia and a low risk of disease, well, the TSH goal should be higher. If they have very high-risk thyroid cancer and a low risk of disease from that, say you're a young, healthy person, you can feel better about having the TSH lower for that 0.1. And this may shift over time, and that's perfectly fine. But again, I think what the field is going to start realizing is that it's, if the free thyroid hormone levels are in the reference range and people are asymptomatic and you're a little bit below 0.1, it's probably okay. But we don't need to have this very strict suppression of thyroid hormone for the rest of your life with a history of thyroid cancer, even aggressive disease. Okay? So in summary, TSH suppression is indicated as part of thyroid cancer therapy. When the TSH is normal or high, outcomes are worse when there's active disease. Consistent form of levothyroxine should be used. Again, I don't think there's anything inherently wrong with the generic as long as it's consistent. Goals for TSH, assuming no contraindications, sort of as close to 0.1 as possible with aggressive active disease. And again, that's where I think, I worry about armor thyroid, where this variability when we're trying to run such a very tight therapeutic window. Stage 1 and 2 disease, just less than 0.5. How many years do we keep this mild suppression if there's no evidence of disease? Nobody really knows the answer to that. I feel pretty comfortable if I have very good studies in a low-risk patient, there's no disease, to kind of ease up on that within 2 to 3 years. And then again, if there's no evidence of disease, low normal. Low normal is the goal. So I'll thank you for your attention. I'll highlight this person who loved my talk at the MER. This was a talk I gave in Vegas. I blame it on Vegas, okay? I know that they were out all night, but thank you for your attention. I'm happy to take any questions.
What happened in Vegas stays in Vegas.
That person stayed in Vegas, yeah. They're still there. Yeah.
So what about menopause? Is there a sort of a recommendation to change
Yeah, so the question's about menopause, and so I'll actually kind of address that two ways. So for women, two big hormonal transitions in your life, pregnancy and menopause, okay? So when a woman becomes pregnant, they generate significant estrogen that affects the liver to make binding proteins, and bound thyroid hormone is inactive thyroid hormone, okay? Someone who has an intact thyroid will compensate for that. They'll just make more thyroid hormone as a woman gets pregnant. But if your thyroid is gone, that pill is your thyroid, right? And that pill doesn't change unless we change it. So during pregnancy, there is a recommendation for people on thyroid hormone to have an automatic increase as soon as they know they're pregnant of about 30 to 50% of the dose, okay? It's a big change, but that is, very good evidence that that's necessary, and you just have to follow patients closely. Not as much data on menopause, but it's kind of the opposite. If you become menopausal and your estrogen level falls, you may have less binding proteins, and your dose may become relatively high, where the thyroid doesn't compensate for that, so you may need to dose adjust down during menopause. So, regardless of whether you're a woman or not, whether you're going through these transitions, there's going to be times when the thyroid hormone levels are going to fluctuate for a variety of reasons. Weight changes. Again, this is a weight-based dosing. If you gain or lose 10% of your body weight, your thyroid would compensate, but that pill is the same, and you may have to adjust the pill. Gut changes, absorption changes, stuff that we just don't really have a great handle on, but all of a sudden, you're feeling fine and your TSH has gone from 0.3 to 4. We just need to adjust the dose. So the bottom line is you need to be followed. The exact interval is a little bit unclear. I get very nervous testing more than, say, every 3 months, because, if people are supposed to be stable, because I just worry that people anchor on their levels and when there's other stuff going on. But definitely at least once a year, you need to have your thyroid hormone levels checked. And they may change over time, and that doesn't mean that the medicine's not working. There's just different changes. So menopause is a time when I think the estrogen effect on binding proteins changes, and the dose probably needs to be lowered, but it's not sort of guaranteed. You just have to check. Yeah.
Don't forget PMS and puberty.
Okay. This gentleman wants to talk about PMS and puberty. We'll bring him up to the microphone. You just come right here, sir.
In terms of hormone change.
Yes. Okay.
Experience with it. Someone who was absolutely religious, no weight changes, taking it at the same time, waiting for 3 hours for their soy, all those things. Still see the fluctuations in say, the 6-month period of time.
Mm-hmm.
Put on tyrosine, seem to be better, but again, suddenly doing exactly the same thing religiously, saw a change in her TSH from about 0.1 to about 2.5.
Okay. So the question's about tyrosine and just variability in thyroid hormone levels. So tyrosine is a purified form of thyroid hormone in a gelatin capsule, where basically all of the kind of binders and the stuff that makes a pill are taken out. So it's a very sort of pure form, and it's really indicated, and there's a very, very, very tiny subset of patients who probably have some reaction to the dyes or whatever makes a pill. That's an indication. People who have malabsorption disorders, celiac sprue, there's some indication that antacids, like Prilosec and these kinds of medicines, will definitely alter the absorption of thyroid hormone. Most of the time you can just adjust the dose to get to the goal, but again, there are patients who just don't absorb or don't tolerate, and tyrosine is a purified form that has very little binders and anything else. Okay. So those are the indications for it. It's a pretty narrow patient population. And then the question is that even on tyrosine, some people have fluctuations despite being robotic about everything in their life. And all I can say is I don't know why. I think that there is variability in testing, and kind of what I'll say, a swing from like 0.3 to 2.5 is a pretty big swing, but I think if you draw someone's blood 7 days in a row, there's going to be a little bit of variability, so you got to accept that these are just snapshots in time. That kind of person, I would just recheck them probably in another month, and if it was still high, I'd just adjust the dose, and I cannot say why that occurred. I think that people can get, pretty good consistency, especially if they have a known malabsorption disorder, short gut syndrome, if they've had bowel surgery with tyrosine, but it's pretty expensive. And the vast majority of people, with things like antacids, you can just titrate the dose of levothyroxine and get the goal. Yep. You.
Can you talk about taking the pills that you mentioned about empty stomach? I just want to make sure the rules still exist about sleeping on an empty stomach. How long for
So the question is just about, what's the best sort of protocol for taking the medicine. So the bottle will say an hour. I'm pretty sure the bottle still says an hour on an empty stomach. I find that to be somewhat unrealistic. I mean, at least like for me, it would be unrealistic. I think 30 to 45 minutes is probably adequate. I have patients who take it when they eat. I have patients who take it at night. I must say that if the TSH is at goal and they feel well, I don't get so bent out of shape about you have to do it this exact way. But people who have difficulty with titrations, with variability, then I think you want to be a little bit more stringent and robotic about it. So again, I mean, the bottle would say an hour before eating or 2 to 3 hours after eating. Relatively consistent time of day. We generally recommend in the morning, but if you're a shift worker, maybe at night is better. So they're really, I mean, again, it's whatever gets you to the target. And so I'm not draconian about it, but the general recommendation that I think would work for just about most people would be first thing in the morning on an empty stomach an hour before you eat.
What about medication? Is there certain, like I take allergy pills, like
Yeah.
my doctor that I could take?
Yeah. So question about medications, interactions. The main, so antacids may decrease the absorption a little bit. The main medicines I was trained to look at and talk about are iron. Iron is pretty well described to block the absorption. We recommend taking anything with iron, even in a multivitamin. I just say take it the opposite end of the day, good 8 hours apart. 4 is probably enough. Calcium, high doses of calcium can maybe block the absorption. And a lot of people who've had thyroid surgery need to take calcium. Try to separate that by 2 to 4 hours. Most other medicines, I think some bile acid sequestrants and some other medicines are on the list. But most medicines I think you can take along with it. Allergy medicines I think are fine. Yeah. Yes, sir.
I take 500 mcgs of levothyroxine and 25 mcgs of cytomel for the last 10 years. And because the doctors want to have my TSH suppressed. Is that what you just said? Is that too much? Can I start adjusting?
So,
I feel really good.
okay.
And I have active disease.
Okay.
That
So.
seems like a lot.
So this gentleman who does not weigh 645 pounds, sitting up here, is taking 500 micrograms of levothyroxine and 25 micrograms of cytomel. Those are very healthy doses. And apparently active disease for a decade and wanting to keep the TSH suppressed. I don't know what the TSH level is. You feel good. You're probably very used to whatever level you've been at, and that can make adjustments, a little bit hard. But I would say that, again, the TSH goal, based on the data that I've shown you that I believe in, is that a TSH below 0.1 is probably not helpful. It could be harmful. You've been dealing with this for a long time. You look fantastic to me, so I try not to, we're not here to provide care during the meeting. But again, the TSH goal with active disease should be in that 0.1 range, but an absolutely undetectable TSH, especially if you're biochemically hyperthyroid, is probably not necessary. Okay.
Thank you.
Yeah.
I have a question for you. You said a word that I've never heard before. This is my first time here. Thyroidologist.
Yes.
And that sounds very interesting to me, because I've only seen endocrinologists in my 23 years.
Yeah.
And so I'm wondering about trying to find a thyroidologist, and if I can't, if you have any suggestions about how to talk to my doctor about suppression from my perspective.
Uh-huh.
And really weighing, I just had a recurrence after 23 years, and the doctor I hit that 45 age, and they dropped my dose, and 2 years later, I had a 1.4 centimeter nodule.
Okay.
So I'm scared about, I have to wait, is recurrence worse or the bone issues in the heart?
Yeah. So the question's about, I never heard of a thyroidologist. That's because you haven't seen a doctor with a big enough ego yet, okay? This is, a thyroidologist is an endocrinologist who specializes in thyroid disease. That's it, okay? And so good general endocrinologists who have an interest or who, keep up to date, they could call themselves a thyroidologist. When you get to academic medical centers, when I was at the university full-time, 90+% of my practice was thyroid, and 80% of that was thyroid cancer, and so that's makes me a thyroidologist, okay? So, I mean, that there's, it's just kind of that interest area and specific practice. The best way to find a thyroidologist is, in my opinion, to go to the American Thyroid Association website, and you can find a thyroid specialist. There's a link there. They just changed their webpage, so I can't describe exactly where it is, but it's relatively user-friendly. So find a thyroid specialist, look at your state, and there's a list of people who are American Thyroid Association members. Now, that doesn't necessarily mean that they do 90% thyroid as their practice, because lots of general endocrinologists see that, but they're at least invested enough to pay the dues and go to the meetings and yada, yada, yada. So that, I think, is the best way to do that. Kind of this topic you brought up, I mean, I think it's interesting as sort of a recurrence after 23 years. The way it is described in the literature is recurrence, but I would argue that that's actually persistence. You've probably had that disease the whole time, okay, the whole time. And I mean, it doesn't make it necessarily better or worse, but I do think that when patients are told that's a good cancer and you're going to be fine, and then 20 years later they say, oops, that cancer's back, that's very disheartening. That's a major shock to the system, and that's a huge weight. I think it's also a weight to say, you know what, your thyroglobulin's positive, you probably have a little bit of thyroid cancer, we just have to monitor it. I mean, that's a huge burden as well, but I would prefer that than sort of all of a sudden saying, oh my gosh, all of a sudden there's this lump, okay? So in any event, there's probably no such thing as true recurrent thyroid cancer. Usually with very sensitive testing, and we have that now, you can detect it. Oftentimes it's at a level where an intervention is going to do more harm than good, but 20 years is a long time. And this is the problem why people say it's a good cancer, because you're 20 years out and you are clearly alive and you look very healthy to me, and they say, oh, look, she's fine. She didn't die of thyroid cancer, but this is a big deal. It's a big deal, okay? You're living with this for the last 20 years. You may need more intervention, so that's why it is clearly not a good cancer. We don't restage people. So just because hitting 45 does not all of a sudden make you stage 3 or something like that. So what we talk about is response to therapy. So if you've been doing pretty well for 20 years, you probably had a good response to therapy. Not curative, but a good response to therapy. And things may change over time, and so some TSH, some mild TSH suppression may be appropriate. So I mean, I can't answer that for you, the pros and cons, but I do think that if there's persistent disease, the TSH should not be 2. Okay, it should be lower. All right, but it probably doesn't have to be undetectable. Yeah.
So if you had a patient that had pretty consistent TSH suppressed for several years, and then within 3 months jumped from a suppressive to a 30 TSH, what would you look for?
I'm going to get in trouble here. So the question was, TSH was suppressed, and then within a 3-month period, it went from suppressed to 30. The top 10 things on the list are compliance. Okay, if people have been compliant, then looking for malabsorption syndromes that can develop over time. A lot of patients with thyroid disease, a lot of patients with thyroid cancer have had autoimmune thyroid disease, and autoimmunity puts you at risk for other autoimmune diseases, which could be celiac sprue, and they don't all happen at the same time. So definitely malabsorption would be the next thing I would look at. Maybe there needs to be some kind of different formulation with like a tyrosine or something if the absorption is not good. You can do what's called an absorption test, where we give patients a 600 microgram, 500 to 600 microgram slug of levothyroxine all at once, and then monitor blood levels, and there's a cutoff of the amount that it goes up, and so that's a way that you can more objectively kind of determine if absorption is affected or not. So those are the ways I would approach that. Yeah.
I had AFib before and some tachycardia, and somebody was like, I've had that before, HFD, I got thyroid cancer. And then my doctor kept me suppressed for 3 years, and then he died. I was kept at 0.03, 0.05, and now I have maybe some valve problems, and I have several tachycardia during the day. He said he lowered my medicine from 137 to 88 several months ago, but it's still at 0.05. I guess it's taking a while to come back. And I'm just wondering if we get my TSH a little, do you think my cardiac symptoms will lessen, or am I like the damage is done?
So the question is about the history of atrial fibrillation prior to all of this happening, and then what are the TSH goals, and if there's still issues. So, I mean, I would suggest that if this occurred before your thyroid cancer, you probably have, either electrical or structural cardiac disease, and excess thyroid hormone can definitely magnify that, but it's probably not the cause in your case. And so, I think that's where you do weigh this balance of TSH suppression versus thyroid cancer with the other things that are going on, and, a more gentle approach would be better, but I definitely wouldn't say that even with a normal TSH, all that'll go away, because I think you probably had an issue prior. So, excess thyroid hormone generally sort of magnifies underlying conditions. If patients, again, at least the studies look like 65 is kind of a typical age cutoff. If they're on excess thyroid hormone, that can predispose to atrial fibrillation, but underlying anxiety disorders, underlying cardiac issues, underlying gut issues, excess thyroid hormone just sort of accentuates that a little bit. There's someone over here. Yeah.
I'm sorry if I missed this in your presentation, but I have two questions. The first one is there any evidence that with the increased dosing of levothyroxine that you increase the risk of heart disease and bone disease and AFib? And the second one is there any medication, supplements, or otherwise that you recommend to kind of counteract during the process of suppression?
Yeah, so the question is about increasing doses and then having subsequent risks of heart disease and bone disease. It really seems to be not the dose itself, but the level, the stringency of the TSH suppression, how high the thyroid hormone levels are. So, there are these kind of arbitrary cutoffs, but remember those are averages. So some people may do perfectly well for 20 years with completely suppressed TSH levels and never have a problem, and some people at a level of 0.2 might have a problem. So there definitely, I think, in general, is an increased risk of all those side effects to lower the TSHs, okay? And kind of what the absolute risk is very hard to determine. Supplements and medications to alleviate that, if there is underlying bone disease and you meet criteria for, say, osteoporosis therapy, yeah, you should be on an osteoporosis therapy. Beta blockers, kind of medications to slow down heart rates may be useful, but I wouldn't say that. I don't prescribe those prophylactically or just because someone needs TSH suppression. I think the answer is to ease up on it and get to these mild suppressive levels, which decrease that risk, but I wouldn't put someone, say a woman who's 45, on a bisphosphonate to prevent osteoporosis. I definitely wouldn't do that. You just have to manage things as they go.
We're going to have to complete the session. Dr. Klopper would be happy to answer questions out in the
Delighted.
hall.
Yes.
So, thank you very much.